All right, thank you. So we'll get started. With that, we will introduce Shelley O'Keefe, the statewide coordinator for person-centered practices.
Thank you. Good morning. Welcome to this OPWDD training on care management, life planning, and service delivery process. This training is designed to provide a high-level conceptual overview of the components of the OPWDD care management health home comprehensive assessment, the life plan development process, and most importantly, how they connect to service delivery. Understanding how these various components fit together is essential to meeting our primary goal, which is to help individuals we serve to identify and achieve life goals that they feel are most meaningful to them. This training will discuss the relationship between the Coordinated Assessment System, or CAS, the IAM assessment tool, the Life Plan Service Plan, and Life Plan Safeguards, and will highlight how these elements connect to an informed staff action plan, which is developed and implemented by service providers that individuals and their circles of support or their planning teams identify. Lastly, this training will reiterate how care managers and planning teams will use a person-centered process to develop, implement, and monitor the life plan and service delivery process to ensure that the process is achieving the outcomes that individuals indicate are most meaningful to them. Kate Bishop, OPWDD's Director of Program Development, will now take you through the collective steps of this process, which will enable you to connect the dots.
Good morning, everybody. Thank you very much, Shelley. We appreciate your joining us here today and the opportunity to share with you some of the key points that Shelley just described in her opening remarks. And I just want to begin by highlighting that we recognize that this is a time of change, and that as we transition from over 300 MSC agencies to now 7 care coordination organizations, it's a significant period of transition, and it builds on the foundation to bring us to a future system that is person-centered and outcome-driven, as well as building on the experience of providers such as all of you as we prepare for a move towards managed care within our system. So what we're talking about today at this time of transition is really an incremental transition process that brings us from the system that we've all been familiar with into a new support system that is really developing tools and strategies to enhance and improve on person-centered practices. But when I say it's new and it's different, I just want to say also how important it is to recognize that the same building blocks that you're all familiar with and know today are really the same building blocks that will be used as we implement new supports and services for individuals. The things that are important as far as planning and developing any sort of support plan for a person who's receiving supports and services is really about knowing the person, listening to them, and understanding what's most needed from them to support their life goals. Developing plans that are appropriate and effective to be able to try to meet those goals for people. And then the need for constant evaluation to make sure that those supports and services are working for the person in a way that is desired by them, and then over time to be able to revise those supports and services as needed to better implement and achieve the outcomes most important to the person receiving support. So none of those good things go away, but what will be different, what we're going to talk about here today, is really how do we use IT systems to implement some of those concepts and improve upon some of the past practices by having a consistent way to communicate and share information with each other. How do we use, during this transition, the opportunity to learn and develop systems that better support people's outcomes instead of defaulting back to compliance-driven systems. You know, we're really trying to shift to outcomes. So these are the key areas that we'll be focused on in today's presentation. As mentioned by Shelley, I just wanted to expand a bit on that, and now we'll move into the specifics of the presentation. So you'll see this information, this slide shows the life planning process cycle and the essential components of that cycle, and it's very similar to the overarching description that I gave in introductory comments, which is understanding the person. Well, how do we understand and listen to the person? We need to use consistent tools for that. And the CAS, the Coordinated Assessment System, the DDP-2, which has been our historic functional needs assessment, and a new tool called the I-AM are the ways in which we listen and document what a person is asking for and what a person may need through the service planning process. And then it's the development of the life plan. The life plan replaces the ISP as the driving plan for delivering the supports and service most desired by and needed by the person receiving support. Staff action plans are the plans that formerly known as habilitation plans. Staff action plans describe the how of service delivery. So the life plan defines the what does a person want, what does a person need. The staff action plans define how. How do we deliver those supports for the person in a way that's effective? Service delivery is the mechanism for achieving those supports for the person and delivering on those supports for the person. And service delivery includes all of the waiver service components as well as other supports within the system, even outside of OPWDD services, in order to ensure that the person has the services that they need and that are most consistent with the goals and the desires that they have in their life. And then with any sort of planning process, reviewing, evaluating, and revising those plans and the support models that are achieving the plans is critical to making sure that it's working and making sure that the outcomes, again, are achieved for the person and by the person. So what is different in this process is now we have some different terminologies that you've begun to hear and you'll hear more about, but also the use of the health information technology, or a HIT system, that really seeks to integrate all of those various elements into documents and support systems of an IT focus so that communication can be improved upon, so that there can be greater consistency in the organization in the way that information is organized and shared, so that there can be improved quality around those communication, continuity, and monitoring of a person's support. So it's that new health information technology system that's different as the service delivery is implemented, and we'll talk more about all of those different components and how they fit together in the overarching system of support for people. So to begin, comprehensive assessment process is required. In the care management process, enrollees must be comprehensively assessed within 60 days of their enrollment and annually thereafter. At this point, that process includes one or more of the tools, such as the CAS, the DDP-2, or the IAM tool. And those tools focus on identifying the person's developmental disability and needs associated with their developmental disability, the medical supports that are needed for someone receiving supports and services, a person's mental and behavioral health status and challenges and needs, if a person may have chemical dependency or substance abuse issues, if a person has social or emotional needs relative to their diagnosis, and what history the person has presented with relative to those social and emotional needs. Those are the types of domain areas that each of these tools have, and they're slightly different. We'll be going through each of those different areas, but the idea here is that there's a consistent and a planful approach to comprehensive assessment. This doesn't limit the need for other assessments in many respects. For example, the CAS may be completed and identify that a person has particular needs, say in the area of speech and communication. The CAS doesn't substitute for what would be a clinical evaluation to look at a person's specific speech and language needs, and that would, as it has always been, be completed by a clinician and a plan related to those defined assessment outcomes developed as a result of that. So, but what we need as a system is this consistency of practice around comprehensive assessment so that that information is consistently informing the development of a life plan. So to speak a little bit about the differences between the assessment tools that are kind of in play within our system, the Comprehensive Assessment System, or the CAS, is a new functional assessment, and it's holistic across the person's life settings and has input from the person and his or her family and circle of support. So when you compare that with the traditional DDP-2, and one of the things that we're looking to make sure is an improvement is that the function of the CAS is to really look at the person, over the overarching needs of the person. So it doesn't vary dependent upon the program that the person may be participating in. So it's really about looking at the overarching needs of the person. The CAS also has a more comprehensive behavioral and medical components with additional domains and has several supplements that seek to get better information relative to a person's medical, behavioral health, substance use, and forensic needs within the system. So that is an expansion upon the domains that are in the current DDP-2. The CAS is completed in a conflict-free manner, which means that it's completed by a trained assessor and that initial assessment is completed by either an OPWDD staff member or designee through contract. Reassessment is anticipated and to be completed by care managers or CCOs as we fully implement the CAS within the system. Currently, the DDP-2 is completed by a variety of providers and people at different levels within those provider organizations, and there's not as much rigor around the expectations for the training associated with completing a DDP-2. So the use of the CAS is an expansion upon what we do today with the DDP-2. There's required qualifications for the assessors who administer the CAS, and as noted in the DDP-2, that those requirements and qualifications are not as rigorous. So the use of the CAS and the implementation around that is meant to inform the development of the person-centered planning process, and to be used with the information that stems from the CAS and regulation. It's required that if that information is available, it's used to help inform the development of a person-centered support plan. In the absence of a CAS, the DDP-2 can be used for that. It's, while I've highlighted some of the improvements that we're seeking in implementing the CAS, the DDP-2 does have information about the person's need areas that should always be considered as part of a person-centered planning process. So the IAM tool is something that is new to many people. Care managers are certainly learning about the IAM tool now as we're in the transition period of implementing the new care coordination system, and care managers are learning the tools that they need to do their jobs, which are expansion. The jobs are expanded upon from their MSC role with additional expectations within the health home service model. So the IAM tool is an even more detailed, in-depth tool that looks at functional needs of the person as well as specific information about the person's interest areas, the outcomes that are most important to the person receiving services, and those outcomes are tied to personal outcome measures. And it looks at the issues of supportive routines that are most desired by the person receiving services. So you can see in this slide the IAM tool, which is an assessment but also a care planning tool, is in-depth and provides practical information about the needs and preferences of the person. It recommends specific services and supports to help the person achieve their hopes and dreams. It delivers 6 in-depth narrative profiles that really are in the person-centered language and in the person's voice, so that when you read the profiles and the profiles inform the life plan, it says, I want to learn more about volunteering in my community, for example. I would like to live in a setting that's rural rather than urban. It's in the voice of the person. So those profiles, which are developed as a result of the IAM tool, really are in the person's voice. When the person's unable to speak on their own behalf, we, as in all service planning, rely on people who know that individual well. Very often it's the family members who are involved in the person's life, or an advocate. It may be the people who are providing supports and services to the individual and know them well, but they help to identify through observation and knowledge and history of how the person reacts in certain situations to help to develop those narrative profiles of what is of greatest importance to the person who's receiving services. The resulting document from the IAM tool offers a list of preferences and supportive routines for the person who can't communicate their own wishes. Some people like to get up bright and early in the morning and have coffee. Other people like to sleep in till 9 o'clock and don't want to be talked to for the first hour of their day. Those are examples of supportive routines. What do people want in their life, in the routines of their daily living, that are going to help them have the most positive experiences that they can have? And as we all like to do, to be responsive to the things that are of greatest importance to them. And as I mentioned, the IAM tool and the resulting outputs from that tool integrate the Council on Quality and Leadership POMs, personal outcome measures, so that, again, as a system, our goal here is to look at how supports and services are helping the person achieve the outcomes that are most important to them. And as we start to identify outcomes, they can be very different at an individual level, but we want them to all relate to consistent measures in the system, and we've chosen those POMs as the consistent measures in the system because they will help to organize around how supports and services are delivered and how we're doing as a system to help people achieve the things that are most important to them. As you can imagine, there's 21 POM domains. If we had over 100 different outcome areas to track, we wouldn't be very effective in being able to say how well the system is doing overall. When we start to break goals and supports that are desired by the person into those 21 different areas, we can be more knowledgeable about how well the system is working for people and what are the areas of greatest interest to the people receiving supports and services. So it's about the organization of those outcome areas that are most important as we implement the new system and the monitoring of that new system. The IAM aggregates all documented information to be used as part of the life plan, including the goals and actions and printed summaries of those different content areas. So the IAM tool assessment summaries that will be identified as a result of completing the IAM tool are the profile summaries that I just referenced. Those are drafted and they are produced in the voice of the person, and they port right over to the life plan, and they fill in those summary sections of the life plan that are the profile sections people are familiar with from ISPs that are now moving into the life plan model. There will be specifics around allergies, around the use of durable medical equipment and supplies. Again, the supportive routines that are most important to the person. The POMS previews, so that when the life planning process is begun, there's clarity around the outcomes that are most important to the person as a result of the IAM tool and the outcome from that tool, so that as the supports and services are discussed in the life plan meetings, those POM areas of greatest interest to the person can be identified and used to inform the development of staff action plans and the habilitative services that are going to be most effective to help the person achieve those outcomes that are most important to them. Preference summary, and that's specifics around what the person prefers in the delivery of their supports and services. There will be an inclusion of goals and actions that are going to be effective to help the person achieve the outcomes. And of course, individual safeguards which serve as a plan of protective oversight are derived from the IAM tool and the results of that IAM tool in the planning process. So how do all the pieces fit together? And tying that to the health information technology is really what's integral to the delivery and the development of effective supports and services for people receiving services. So you can see from the earlier slides that the CAS and the DDP2 are kind of the broad, overarching identification of functional needs assessment for people. The IAM tool, which is also an assessment and a care planning tool, really digs in deeper. So you're starting at the broadest possible level, then starting to dig in deeper using the IAM tool, and then digging in even deeper as we start to develop the life plan. The life plan identifies the goals and desired outcomes of the person, the habilitative goals. You know, what does the person want from their habilitative services? What are the goals that can be worked on by the habilitative service providers so that those outcomes that are most important to the person can be achieved? What are the strengths and preferences of the person? How's that incorporated into the person's life plan? The clinical and support needs. And what's a bit different here when we think about support needs is in the past there was really a focus more on the type of program that the person was in as opposed to looking holistically at the person and looking at the way that supports and services were developed to achieve the outcomes that are desired by them through the assessment process. So the idea is that the development of strong safeguards, for example, or supports for achieving outcomes and goals of the individual shouldn't be reliant just on living in the most robust service model or the most structured service model, such as a certified residential setting or certified day habilitation program, but that incorporating some of the natural supports that people have, so both paid and unpaid supports, and looking holistically at the person's life and developing safeguards that are effectively supporting the person in a variety of support models is something that's an expansion from the prior expectations within the system and within the old ISP plan model. So those are critical differences, and housing those goals, safeguards, strengths, and desired outcomes for the person in one integrated life plan using the HIT or the health information technology as a support is integral to achieving all of these things. So that's what we're going to spend a bit more time on defining for you over the next several slides. So the person-centered life plan development, and it's built upon, again, the completion of those assessments, the CAS and DDP2, then the IAM assessment that's more of a detailed assessment and care planning approach, which provides specific information. The person's life plan is developed, and it's a collaborative process, and it's a recurring process, and it's driven by the person. The person-centered planning regulations that are in place for habilitative service plan development remain in place through all of this transition, and those person-centered practices are required as part of the life plan development, and it's integrated into the health home service. So what's expected is that the person is driving that process, identifying the goals and desired outcomes that they have, and that people who may know the person well, if the person's not able to describe what they want, are incorporated into that planning process. The life plan needs to describe who the person is and what he or she wants to accomplish, and who or what will help that person accomplish their goals and valued outcomes. It integrates all services and natural support. So again, that concept of integration. Understandable to the person, the life plan must be understandable to the person. It must be identified in a way that is shared in a digestible way for the person who's receiving supports and services. And that may not be in a written form. It may need to be verbally shared with the person. Sometimes people use pictorial demonstrations of goals and outcomes to better share what that life plan is in relationship to the person and what their ability is to understand the information in their own life plan. It must be finalized and agreed to with the person's informed consent. So those are things that are expected as part of the life plan development. And again, it's a living document subject to continuous updating and monitoring by the care manager. So if things change, the life plan should change and be updated accordingly. That could be changes about a person has gained skills and is ready to move into more independent supports and services, or have more control over their own environment, or someone who may have changing needs that requires additional support and additional services in place to meet their changing needs. Change is bidirectional, and it should be, a life plan should be adjusted whether a person is making strides or whether a person has increasing needs as part of the ongoing continuous planning process. So what are the life plan sections? These are very similar to what you're familiar with in many ways within the ISP. So again, the building blocks remain very similar. They're just organized and terminology is different. One of the key differences, of course, that I keep hitting home on, and I hope you're not getting sick of hearing me say it again and again, but the use of the health information technology is a critical added component, and it's one of the reasons why we need to be very clear in our expectations here about the development of the life plan and communication relative to the sections of the life plan. So the profile is a life plan section, the first life plan section. It includes the person identifying what is, who they are, where they live, what relationships are important to them, what makes them happy, what makes them, what their goals in life are, and the interest areas of greatest importance to them. Section 2 are personal outcomes, and that's, again, as I referenced earlier, the valued outcomes for people receiving supports and services are organized around the CQL personal outcome measure, and this section of the life plan is really about what does the person want, what's important in their life, what are they asking for in the development of their supports and services and the planning related to that. Section 3 is about the health and safety support. Very often in some of the ISPs that exist today, we see just reference to see the IPOP, or the IPOP may say see the ISP. What we're seeking to do in the development of the health and safety supports and what will be required is that the life plan section that includes the specifics around the health and safety supports that a person needs are holistic around the person. And I'm going to be saying this again in several slides, but I'm going to take the opportunity to repeat it a few times because it's an important concept. So the life plan will identify the health and safety support needs of the person. That will be the active location for ongoing identification of those health and safety support needs. Any plans, and that's developed based on the assessments that have been completed that we talked about in the prior slides. So if someone has an identified area of need related to their communication or their dining or safety when they're out in the community, those are things that are discussed as a result of the assessments that were completed in this health and safety section, and they're documented there. And then any supports and services that are provided by HAB providers will relate back to that Section 3 of the life plan and must be consistent with the details in that life plan. And we're going to go through this again, but I'm just taking the opportunity to highlight it here so that we start talking about it in a way that will make it real as we move into the development of the habilitative services and expectations there. Section 4 lists the home and community-based waiver services and other Medicaid authorized services for the person. And Section 5 identifies the supports that are in place for the person. So to talk a little bit more about the individual safeguards and plan of protective oversight are one and the same and incorporated into the life plan. They are applicable across all settings, and they include the person's desired actions related to safety and risk prevention. So the safeguards, again, are integrated into the life plan, and they include areas that are mentioned here: dental, vision, medication, fire safety and evacuation, the person's mobility, the personal support needs of the individual. This is not an all-inclusive list. This is just examples. And as always, and this is, I know, been a long-term discussion, there's often some interest in discussion around dignity of risk issues as safeguard plans are developed, so that the person's voice and their desire for as much independence as possible can be respected as part of the person-centered planning process. But the key element to the individual safeguards is that all of the particular domain areas that are in the IAM and which inform the life plan will really be explored by the person receiving supports and services and their planning team, which includes service providers and their family and advocates. So the idea here is to take all of the information around the needs of the person that have been gleaned from the assessment process and to develop a comprehensive safeguard plan that can be implemented across all settings. And when you think about, some of our current challenges and why we focused on this area so carefully in the development of the new system and the development of the life plan and the supporting technology to deliver that, is that in many instances, you might have had a change to a person's need, and that need got captured in one service environment. Say, for example, in the rehab service, the person had an updated plan related to their diet or related to their supervision needs associated with an event in their life that maybe happened over a weekend, and that communication didn't happen to the day supports or the job supports the person was participating in. And as a result, what we've seen in some instances is that's where negative events may occur. Someone may have a bad outcome and an incident related to the fact that information wasn't shared in a timely way. So our quality improvement structure around using the health information technology system is to improve that communication across providers and across members of the planning team, so that we aren't in a situation where changes are made in one program model but not in another, and ultimately the person doesn't get the supports and services that they need. And as you can imagine, if we don't have a centralized way to capture those needs and keep them up to date, we'll never achieve that goal. So having the life plan be the location where that information is housed and maintained and kept current is critical. So again, I'm just going to reiterate a couple of those points. Life Plan Section 3, which is the individual safeguards, is the compilation of all supports and services needed for the person to remain safe. It defines the overarching need areas for the person in consistent terminology, so that one program model isn't using a different terminology or different phrase or different level of supervision than a different program model, so that we've got consistency of practice across those support systems for the person. The individual safeguards are person-focused. They're not unique to a program. Now, people may do differently in different programs, and that can be expanded upon in the planning documents. But generally, the safeguards are person-focused. They're about the person, not the nature of the program that the person is participating in. The habilitative service providers must ensure that staff action plans and internal guidance, and we use the term internal guidance to define other documents that define the support needs of a person. And I gave a couple examples here as behavior support plans or travel plans. Those must be consistent with the life plan safeguards. So the goal in all of the planning process and plan development and the changes that happen to plans over time are all about ensuring that there's consistency across the life plan with those staff action plans or other internal guidance. There shouldn't be things that are different across each of those documents, and the life plan remains the place where that information is housed and up to date at all times so that it can be reflected in the downstream providers' support plans in a consistent way. And again, it must be updated in real time for use across the different service providers. So care managers, now we're moving on, and you may say, why did she start with Section 3 instead of Section 2? And the reason for that is that the safeguards are really one of the critical elements and a starting place for developing the habilitative support. So the first requirement is to ensure that a person has the supports they need for safety in their life, and then upon the securing of safety plans and supports for the person, additional goals and personal outcomes then have a strong foundation upon which to be developed and implemented to help the person achieve the things that are most important to them. And because we know that those safeguards need to carry over into the development of the habilitation plans, now known as staff action plans, it's important to make sure that there's an understanding of those safeguard needs as the staff action plans are developed. So again, just to review, the life plan hosted within a health information technology system includes the goals and desired outcomes for the person, their strengths and preferences, their clinical support needs. It includes the services and the providers who are involved in delivering those supports for the person, and the safeguards that are necessary for the person to be healthy and safe. And then the habilitation provider develops the staff action plan. And again, remember, we're going from the what does the person want and need to the how. The staff action plan defines what the support staff need to do to help the person achieve what they want and need from their supports and services. So the staff action plan is about the how. How does this particular person meet the goals and achieve the desired outcomes that are most important to them? So habilitative services, and the definitions here have really not changed. They are designed to assist in acquiring, retaining, and improving self-help and socialization skills, as well as adaptive skills necessary to reside successfully in home and community-based settings. So providers develop a staff action plan to implement those habilitative services. The staff action plan is required for each habilitative service received by the person. The staff action plan describes how, again, we're back to the how, habilitative staff will assist the person to achieve his or her defined habilitative goals and valued outcomes from the life plan. So providers develop staff action plans, again. The staff action plan details how the individual's needed safeguards from the life plan will be met. The staff supports and or other specific details on protective oversight measures to ensure the health and safety of the person. And I think this is a flow that has always been the flow that has been expected within our system, that there's a person-centered planning process, that the person is driving what's most important to them in the development of both their goals as well as their health and safety needs, with the support of family members, advocates, and service providers who know them well in that planning process. One of the things that is different in the development of the staff action plan is that as a result of that life planning needs, there will be specific goals identified that are actually assigned to providers to deliver the service. So in some of the prior processes where you'd leave the ISP meeting and kind of the habilitative providers would go back and work with the person and their team, and they would develop the habilitative plans, which would get sent back and ultimately stapled to the ISP to make it a complete document. Now the goals are built into the life plan, they're assigned, and everyone's included in the development of those goals driven by the person, but it's incorporated and integrated into the life plan using that new integrated technology. And those outcome areas, and we're going to go through a couple examples, but those outcome areas desired by the person are then assigned to providers to deliver on those specific goals. So instead of the habilitative goals being attached as a separate stapled document, they're integrated into the life plan. And then the action plans really describe the methods or the how of how those habilitative goals will be achieved for the person, you know, with supports from the provider of service and the staff who provide those supports. So that's a critical difference and it drives the flow that we've always envisioned, but we see this as a quality improvement step because the HIT system will help us ensure that that flow is happening in a truly person-centered way. So if additional details are needed on safeguards, so again, the safeguards built into the life plan are going to be fairly broadly defined. Those broad safeguards must be implemented within the staff action plan system, and they can be expanded upon. And we'll have some examples of that as well. And the life plan will assign the valued outcomes or goals to the provider with the following labels. So those assigned goals that I referenced that will be developed during the course of the planning meeting. So people will, for people who are currently in services, will be at that table for those planning meetings, will be identified as either a goal, a support, or a task. And those are things that flow right from the IAM assessment care planning tool to the life plan and get identified within the life plan as either a goal, a support, or a task. And now we'll talk a bit about what does that mean. So goals are assigned to providers that are then translated into staff action plans with the person's valued outcomes identified. And maybe an example of a valued outcome here that we can think about to live more independently in the community is the area of focus most desired by the person receiving support. So a goal is about teaching. Teaching a person a new skill. And teaching the person to take public transportation would be something that would align with that outcome area for the individual. But a goal is really about learning and teaching on behalf of the person receiving services. A support, identified within the life plan as an S, is about providing support. So it's support that will help the person achieve the valued outcomes that is most important to them. So for example, you can provide a support of providing diet counseling for healthy food selection. And that is a support that's necessary for the person. They're not necessarily learning all sorts of nutritional information, but they're getting counseling about healthy food selection so that they can make good choices. And then lastly is a task. A task is really a one-time activity, and it gets identified. It's just really Think about tasks as those things that you probably would have historically written down in your notes to do after a planning meeting that can now be incorporated into the IT system for greater consistency and follow-up and monitoring, as mentioned. Remember, all of this is about improving quality, helping to facilitate tools for people to be able to achieve the strongest care management and service delivery models for a person receiving services. So tasks are one-time activities. It does not meet the definition of a habilitative service, so it's not billable. It could be things like one-time events. Take a person to view an apartment. Follow up on reaching out to an advocate on behalf of the person after this meeting. Look for a new provider for dental services in the locale where the person lives. Things that are one-time activities that need to occur and should be follow-ups to planning meetings and life plan development, but are not a goal or support in support of valued outcomes for the person, and therefore don't meet the requirements for habilitative billing. So again, here's an example of a life plan that's identified some performance outcome measures and goals to the provider. A life plan POM goal could be that people, for this particular person, would be that people live in integrated environments. So that's a POM. I'm not sure how many people on the call are familiar with personal outcome measures. There's been a lot of training in this area. There's a lot of information on our person-centered planning webpage. But one of the POMs is people live in integrated environments. So as a result of that particular area, personal outcome area for that individual, a goal or valued outcome is I want to live more independently in the community in my own place. And that would lead to the provider assigned goal for residential habilitation. If the person is receiving residential habilitation, a goal would be to teach the person to identify and respond to safety issues, environmental concerns, et cetera. Now, each of these three things would be in Section 2 of the life plan. So that's where we start to get to the integration within an IT system of the habilitative goal. So you see the provider assigned goal for residential habilitation, that goal will be in the life plan and will be received by the provider of service to then develop the staff action plan focused on skill development related to learning safety skills. So it's really the step one of the habilitative service development that flows within the life planning meeting. So it's why the habilitative plans or the habilitative goals are integrated within the life plan, and then they inform the development of the staff action plan. So I think you can see in this example how those pieces fit together. Remember, we named this presentation Connecting the Dots because we're trying to make sure that all of the different component parts are fitting together in a way that makes sense in the service delivery model. So those first upper three boxes will be included in the life plan, and the residential habilitative staff action plan will be developed in much more detail about how those things will be delivered for the person receiving services within the staff action plan that's developed for implementation at the service level. And here's another example of an assigned life plan goal to a provider. So the life plan identifies the goal or valued outcome that people have the best possible health. Again, that's a POM, people have the best possible health. My goal, the goal to achieve that outcome is I want to lose some weight so I can feel better. And then the assigned goal to the provider, which is a support in this instance. The last example was a teaching goal. This example is a support. So it's provide an exercise program to make sure the person wants to lose some weight and feel better. So how do we achieve that for the person? We help them with providing an exercise program. That support will be identified in the life plan. The community HAB staff who are working with the individual will work with them to determine what kind of exercise program. So again, we're back at the how. Staff action plans describe how that goal and outcome will be achieved for the person. What kind of exercise program the individual is interested in, what will help the person engage in this activity 3 times per week for 30 minutes. So the community HAB staff action plan would include the specifics around that person and the exercise program that they wanted to participate in. Maybe it's 2 days of walking and a day of attending a local gym, you know, whatever makes the most sense for that person, and that will vary person to person based on what is of greatest interest to them and emerge in the staff action plan development process by the service provider. So what's required in staff action plans? First is identifying information. The name, Medicaid ID number, habilitative provider, so who's delivering the service, the PCO that the person is associated with, the habilitative service that's being delivered, the date of the life plan and/or staff action plan review meeting. So those dates would need to be identified within that identifying information section. Number 2, the individual habilitative goals or valued outcomes and provider assigned goals. So those skill acquisition and retention areas, staff support, or exploration of new experience, those are required within a staff action plan to identify what is being provided through the service by the provider to achieve these areas within a habilitative model. And then the individual safeguards must be included, and that would be included within the staff action plan detail. We anticipate that the staff action plan may have more detail, would typically have more detail than what is in the life plan, but the safeguards in the life plan must be incorporated, aligning with anything that's developed within the staff action plan. There should not be, as we talked about earlier, there should not be any inconsistencies, and the safeguards in the life plan are where we start with identifying the safeguard needs in the development of the staff action plan. And then individual specific protective oversight measures that the staff must implement to deliver those safeguards. Again, how? How will the staff provide the supports to achieve the safeguards that are identified for the person in the life plan? So the staff action plan program standards. Staff action plans are developed using person-centered planning processes, and they must be person-centered, and that's part of the person-centered planning regulation. Staff action plans must be in place within 60 days of the start of the habilitative service or the life plan review date, whichever one comes first. So we know in some instances there may be a service that begins prior to the life plan meeting, and if that service starts prior, then the time frame for getting the staff action plan in place aligns with the service delivery and must start 60 days from the start of the service or the life plan review, whichever one comes first. Staff action plans are provided to the care manager no more than 60 days after the life plan review meeting. And this is a change. We know that by defining those outcome areas and the goals and supports that are most important to the person, to the provider, may require some change, at least for people who are transitioning from the current ISP and HAB plan to the new life plan and staff action plan, that there may be a need to update and change the existing plans more holistically. So this 60 days is an increase from the earlier requirement of a 30-day turnaround time period, and that's in order to really facilitate the systems change and person-centered practices that we want to ensure are part of the overall implementation of the new system. Staff action plans must be reviewed at least twice annually and revised as necessary. Its recommended occurrence is every 6 months and to be coordinated with the life plan review. Staff action plan review and revisions. Purpose is to reassess the effectiveness of the staff action plan. And remember back to the original cycle that we spoke about, the cycle, which is a similar cycle to what you're all very familiar with today. If there are changed needs, if things are different in the person's life, their support needs, their desired outcomes, the staff action plan should be revised to reflect that. It's recommended that the staff action plan be coordinated with the life plan. Timely communication between the habilitative staff and the care manager is necessary. So remember, with the life plan being the active defining document for the service delivery expectations, communication is critical. And making sure that the care manager has that information in real time so that it can be shared. You know, remember, the benefits of the IT system, once it's fully implemented and developed, is to increase communication and make sure that people have the information they need in a timely way to support people more effectively and increase quality. So if that information isn't shared in a timely way, the benefits of that system are not achieved. So that's why that timely communication is so important. Must consider the person's progress and any prevention of regression. The review must include a discussion about the services and supports that are provided, any challenges, any new strategies or methodologies that may be needed to help the person achieve those outcomes that are most important to them and their health and safety needs. And to establish agreement on the objectives, like what is the person wanting and how do we as a support system help them achieve that in the best possible way. It must include recognition of the accomplishments of the person and the person's satisfaction with the staff action plan. So is it working for the person? Our goal is to move, and we've been talking about this, and you'll see as I move into the quality oversight slides here, but one of the significant goals in this system transformation and system change is to really move away from a compliance-driven system. So we don't want to get really good at documenting that we completed the tasks associated with a person's service plan and say, well, we're doing great, our documentation was perfect, we got 100 on our audit. It's got to be about, is the service working in a way that helps the person achieve the outcomes that are most important to them? And this is one of the steps, having this information organized in this way, documented in this manner, will start to build the foundation for us to make those outcome judgments that are going to be so important over time in service delivery. And there also are paths towards moving into a managed care system. So achieving the outcomes that are most important to the person is what is critical in this systems change activity. So changes to the life plan. The life plan is a person-driven living document and must accurately reflect the meaningful goals, needs, and safeguards and preferences of the person. The safeguards section must always be accurate based on the change, and this is reiterating, I think you've heard it a few times in the course of the presentation, and it's something that's not, that I don't want to stop saying because it is a critical element. And any changes in the person's life that affect information in the life plan must trigger an update to the life plan, and that could include both interest change and safeguard change. So the prior slide spoke of what is a Sentinel event, and a Sentinel event are really those episodes in a person's life that we know will require a plan review. There could be other events that occur that require life plan updates and safeguard updates, but as you can imagine, when someone has a significant accident or an event that results in serious personal injury, those are things that may require reassessment again. They may require, certainly may require updates to the life plan and the staff action plans that support an individual. A major medical event, think about someone who's now had, has developed heart disease and had a heart attack perhaps and has some significant changes to their ability to be mobile and active, has special safeguards, someone who may have had a stroke or another neurological event. that's impacted communication or has impacted their mobility. Those are things that would need reassessment and going kind of back through the process here, a new cycle of service planning to make sure that the life plan is still in effect and appropriate for that person. Other areas of significant event is a major psychiatric episode or decompensation, someone who's got an increased need for psychiatric hospitalization or frequent use of a psychiatric emergency room assessment. Those are events that would require review. And also, we never want to forget that sometimes people are going through a very difficult period and or just learning and growing as everyone does, and they experience some significant improvement. Maybe they are someone who had a need for very high intensive services for a period of time because of a trauma in their life or because of some physical needs that they had, and now those things are really improving, and their baseline is changing, and the baseline is now a higher level of capability and strength in their ability to do things independently. Those should trigger a review and a reassessment so that as a person's needs are changing in a way that is a reduction, those things are incorporated in the life planning process just as much as we would a changing need for increased needs. And that's important to consider in all of the life planning activities. So a question that we presumed would come up is, what about those short-term situations? Do those require updates to the life plan? Well, if someone has a much more acute episode or a need, something similar to, say, the use of sedation for dental treatment, maybe they've had a short-term illness, those are not things that require the life plan to be updated or changed. They would be communicated to the support staff who are helping the individual through the normal day-to-day documentation requirements and monitoring that you would put in place in those kind of acute situations. So we don't want to overstress the system with, once a week changes to the life plan. It's really about when there's been, an overarching need to the safeguards that are presumed to be long-term that will need to be adjusted within the planning process. So we've been talking about health information technology and want to, again, reiterate that the health information technology system is an electronic information sharing system, and it must be used if it's available and accessible. So just to give us a point of reference and a framing of this, we're doing this training today based on the future vision for all of these component parts and how they'll fit together. The CCOs are still in early stages of implementing and developing all of these systems. We are in the process, the CCOs are in the process of developing life plans for new people coming into the system using the assessment, the IM assessment care planning tool, and developing life plans for those new people within 60 days of their life plan meeting or service, as just mentioned in the prior slide. But the use of the health information technology system isn't going to be an on switch that everyone has starting tomorrow. This is something that will be incrementally implemented over time as the CCOs get their IT systems up to speed, get the life plans developed within that system, get the portals for communication across the service providers and the CCOs in place. So don't expect that all of this is happening tomorrow. This is something that will be phased in incrementally as life plans are developed. The CCOs have a year for the vast majority of people who are transitioning from ISPs to life plans to get those life plans in place. We expect that it will happen during the course of the normal ISP/life plan review cycles over the course of the year, so that during annual meetings, the transition to life plan is what is anticipated. Although we're giving some relief for these early months, well, the newness of all of these systems and the impact of the significant change of moving from MSC agencies to CCOs is actually implemented and kind of stabilizes. So you will see these things emerging over time. But I want to talk to you today about this as the vision and the goal of where we're headed as we move forward within the transition to life plans housed in the health information technology systems. So the HITS is an electronic information sharing system and must be used as available and accessible, as I mentioned. If it's not available or accessible, then other mechanisms for prompt communication must be used to communicate to the care manager so that providers can be updated. So that could be an email with attached documents. It could be faxed or scanned documents sent to the care manager. But the critical element is we want to use the IT system as it is available, and that will be required, and that if it's not accessible, that timely communication must be completed. We've got to ensure consistent and timely and comprehensive information sharing between the providers and care manager. Remember, the HITS system will be a tool to improve communication and consistency across the system. Providers' access to the individual and individual family members and advocates are permitted within the HIT system. So ultimately, when all of the system is kind of using the health information technology, there will be portals for the individual, for families, for providers to be able to access that information directly from the health information technology system. And that will be very helpful for very, very many people who've come to rely on technology as a way to share information and identify good communication skills. So the life planning cycle, just to review and evaluate some of the key questions that are explored with the person, and that is the life planning and service delivery process helping to achieve a person's meaningful life goals? So that's always at the core of the planning process and the evaluation of the existing supports and services in place with the person. Is the person involved in life experience that they are valuing through their supports? Is there improvement in the person's life as a result of the supports and services that they're receiving? Those are key elements of the life planning process and the review of all of the life plan development as well as the staff action plans that support the person's habilitative goals. So as a system, and this is something that was defined within the CCO application process, and it's where we're moving as a system, and we've been talking about as a system for many years now. The system measures that OPWDD is looking at, and where this information within the life plan and the related service plans will be most important, is to look at those system measures of, does the person live and receive services in the most integrated setting? Does the person have community participation experience that are meaningful to him or her? Does the person have meaningful relationships with their friends, family, and others that are important to him or her? Does the person experience personal health, safety, and growth opportunities? And does the person exercise choice and decision-making in his or her life with his or her daily schedule to the extent possible? And these are the kind of systems measures that have been emerging over time. They're defined in the person-centered planning regulation. They're expected as part of the HCBS final settings rule. They're incorporated into the life planning process and expectations related to that. And they are incorporated into the quality improvement oversight. And those are the last couple slides we have, and then we'll have a chance for some questions. All of these elements, again, are about helping ensure that the system is supporting the outcomes most important to the person, and that the plans of support in place for the person are meeting their health and safety needs. So the quality improvement person-centered review tool, and you'll see on the PowerPoint that there is a link to that tool so that you can look at it in greater detail, because I'm just touching on a couple of key elements today. It's about looking at the quality of life summary and the quality of life in general from the service delivery that the person is receiving, and making sure that it's, again, helping the person achieve the outcomes that are most important to them. In order to move, again, from a compliance-based system to an outcome-based system, we need to start to build the right measures to ensure that we are identifying if outcomes are achieved that are in line with what the person wants and needs from their supports and services. So the types of examples and the standards that are built into the person-centered review tool include the person's maintained in their desired role in the community, the person is living safety in the community with informed choice of that living environment, the person's satisfied with the supports that they're receiving, the person is contributing to advancing towards and achieving the specific goals and personal outcomes that are most important to them. And again, just a few more examples of systems outcomes on relationships. The person is engaged in relationships that are important and meaningful to him or her. And about community participation experience, the person is engaged with full access to the community. You'll remember that from the HCBS settings rule. Community-based, and their interests and preferences for meaningful activities are incorporated into their life. The individual regularly participates in unscheduled or scheduled community activities. The individual is satisfied with their level of access to the broader community. So those are the kind of things that are looked at as part of the person-centered quality review process, and you'll see that they very directly relate to the life plan and the staff action plan expectations that we've been talking about today. One thing that you may see as missing from the documentation from this conversation so far is what about service documentation? The service documentation and billing for Medicaid services really remains consistent with the current ADMs in place today. So those are not changing. You know, what's changing is the plan development, the relationship of the life plan to the staff action plan, but not the current billing standards at the service level. So again, valued outcomes are the person's chosen life goals and the driving force behind the services and supports that he or she receives. And I think that's been the common theme through the course of all of the different elements and the connecting of the dots today. And to pull it all together, just a recap of where we started, which is to say that the assessment process informs the life plan, and the life plan, which incorporates all of the person-centered practices that we've been talking about, informs the development of a staff action plan, and that life plan integrates the habilitative goals of the person so that the staff action plan can say how those things will be achieved. Service delivery is the implementation of that plan, and there's a need for ongoing evaluating and revising dependent upon what's happening in the person's life and adjustments as needed relative to that, and the cycle continues. So with that, I'm going to stop and see if we have any questions from the material that I've presented.
Yeah.
Okay, everybody, we're back online. This is Kate Bishop again, and we just needed to take a quick break to see what questions were coming in and to strategize on our responses. As you know, there's going to be another session, and I know a lot of the questions that emerged related to the questions around the ADM that is very soon to be released. And that is, we'd hoped that it would be out prior to this training, but it's in the very, very last stages of review, and we anticipate that it will be able to be released in the very near future. But the ADM will describe in more detail the expectations related to the staff action plans. It will specifically identify some of the program and billing questions that have come through in the question and answer session here today. So that will be coming out very shortly. We would be taking the questions that have come in here today, and we'll go through some of them that are relevant to the presentation, but don't want to get sidetracked on some of those very specific kind of things that will be answered by the ADM, so that you're clear on what those particular expectations are. There was a question related to, will there be a template that's required? And there will be a template that is suggested or offered, but it will not be required, but it will include the essential elements of what needs to be in a staff action plan, so that you will have a guide to how to develop the staff action plan. You will see that there's a lot of similarity with what's in your current HAB plan development. So, you know, I don't want people to feel like this is something that will be totally foreign. It'll be very similar, but there will be some critical differences that we highlighted during the course of the presentation. So with that, I'll see if there's some other questions that can be answered here.
Does the staff action plan ADM outline the time frame for coming into compliance with the development of staff action plans, and if there's changes to HAB plans now?
Yes, the ADM will identify the specific time frames for coming into compliance.
Another question that we received was, how do these changes from the HAB plan to staff action plan impact self-directed services and our support brokers? Will they complete the staff action plan, or will care managers, and are there any changes?
That's a great question, and as in today's world, where the support broker develops the habilitative plan for the habilitative services in a person's self-directed supports, which are community HAB or STEM, the support broker would also be required for doing the staff action plan for people who are choosing to self-direct their services.
Thank you. Another question that came in is, will care managers be expected to complete the CAS as well as the IAM assessments moving forward?
Okay, that's another good question. And the CAS is completed initially by either the state or a agent of the state, a contractor of the state, and then it will be completed by the CCOs in a reassessment process. We haven't implemented that yet. It's going to be coming soon. We're letting the CCOs stabilize and get all of the, get their new organizations on the ground, and then we'll begin working with them to train them in completing the CAS. The CAS is different than the IAM. It could be potentially completed by the same person, or it could be different roles within the CCO organization. We're not going to be requiring something specific for that, so different organizations may manage the completion of the ongoing CAS assessment differently, but it could theoretically be done by a care manager, or it could be done by somebody in a different role within the organization.
Another question received was, if an individual is receiving state-paid services, will they need a staff action plan, or is it just for waiver services?
It's just for waiver services. So the state-paid services, such as like family support services, are not something that requires staff action plan. It's for habilitative services in the waiver. Yeah, we're just reviewing the questions. I think that covers pretty much everything. And again, when we issue the ADM, we will put frequently asked questions document together, and this will begin to identify what those questions are that people have based on the presentation today. There will be additional training for care managers relative to this issue in the next Care Manager Quarterly Conference that's on September 12th. And we have another training available on September 17th. And these will be posted, you know, they're being recorded, and they will be posted so that they're available as a resource as questions come up for reference. And again, we will be using the questions that have emerged from these sessions to develop additional guidance that can be issued in conjunction with the ADM as it's released.
Yes, and can you, the PowerPoint from this session will be posted to the OPWDD website and will be available in the near future.
Okay. With that, I'll say goodbye. Thank you all very much for your time, and have a good day.